And I'm going to be presenting the referral experiences of service users in Nigerian urban slums. Okay, so outline, introduction, method, result, discussion, and conclusion. Okay, so generally, the Nigerian health system has a weak referral system, weak referral pattern, with poor continuity across primary, secondary, and tertiary levels, making it ineffective. It gets worse in the urban slums with the widespread presence of informal healthcare providers. And informal healthcare providers would include the traditional birth attendants. Oh, sorry. What's that mean? Okay. So the informal healthcare providers would include like the traditional birth attendants, the traditional bone setters, the patent medicine vendors, and drug peddlers. These informal health providers contribute to Nigeria's weak referral system because of a lack of integration. So generally, you should have a system where the informal health provider, when a service user goes to the informal health provider, the informal health provider should refer to a primary healthcare center in a situation where they can handle. Then you have the primary healthcare center refer to the secondary when they can handle, and then the secondary refer to the tertiary when they can handle the situation. But that is lacking because some people, sometimes the service users mostly go to informal health providers because they are very accessible to them, and they could always locate them at, they're always open at always. So since IHPs operate outside the formal healthcare system, there is limited information on how patients navigate referrals. So the aim of this study would be to provide evidence of the often overlooked referral experiences of healthcare consumers in urban slums in Southeast Nigeria. This information is required to improve how referrals are undertaken in the health system, especially amongst IHPs in urban slums. Method. So our study area is Enugu State and Anambra State in Southeast Nigeria. So we did a purposive selection of 6 LGAs in Anambra and then 6 LGAs in Enugu State. We also selected, so when we came to each of these LGAs, we selected 4 slums from Anambra State. These slums are slums with functional primary healthcare centers, because some of these slums, some of these urban slums do not have a functional primary healthcare centers. So we did that in Enugu State, and we also did that in Anambra State. When we went to each of the slums, we had households with women of reproductive age and with at least a child under 5 years. It's important to note here that this study is part of a broad study that Health Policy Research Group undertook with the Chorus Consortium. Data was collected using a pre-tested interview administered questionnaire, and analysis was univariate and bivariate, basically. Okay, so the results section. We interviewed 1,025 respondents in both of these states, and out of these respondents, 95.9% were females. That was our focus anyway. So the average household size was 5 with a mean respondent age of 32.3 years, and nearly all of them were literate. Of these 1,025 respondents, only 76 of these people use referral services in the past 3 months. The most common source of referrals were the patent medicine vendors, which are commonly known as chemists, and they referred 31.6 of these 76 respondents. These informal health providers, like I mentioned earlier, the traditional birth attendants, the traditional bone setters, mostly referred to private clinics Remember I said that in an integrated system, you should have a situation where an informal health provider should refer to a primary health center, and then the primary health center would refer to a secondary when they can handle a case. But we usually have situations where service users present first, sometimes to private clinics and sometimes to even tertiary hospitals for cases that a primary health center should handle. However, only 7.9% of these referrals had their appointments successfully booked by the facility that initiated this referrals. And if you look here, you're going to see where consumers of healthcare services were referred to. Okay, sorry, let me start here. So facilities that initiated referrals, most of them, like I said, they were mostly patent medicine vendors, and most referrals were done to private clinics. So none of these informal health providers referred patients using a referral slip. So a proper referral should have you should have a slip where you say, okay, this is what is wrong with this patient, this is why I'm referring this patient. And so you know the treatment has already been undertaken and what next to do as a healthcare provider. Our logistic regression analysis revealed that households in Enugu slums were 209% more likely to be referred to higher level of care than those in Anambra State, while wealthier household had a 17% greater chance of referral. This result emphasizes the key role of socio-demographic factors in assessing advanced healthcare. So, discussion and conclusion. Our study confirms that referral practice in urban slums of Southeast Nigeria are inadequate, which undermines the continuum of care and weakens the overall health system. Specifically, the inefficient referrals from informal health providers to formal healthcare facilities are a major contribution to this problem. Because informal healthcare providers are typically the first point of contact in these communities, it's essential to provide them with targeted training on effective referral practices. In addition, establishing formal linkages between informal and formal health system could significantly improve service delivery. To further address these issues, future studies or future research should include a balanced representation of both male and female service users, because our study was focused on female, right? And use both quantitative and qualitative, our study was focused on quant, methods to gain deeper insights into challenges and opportunities for enhancing referral practices. Thank you.
Thank you very much, Madam Obi, for the good presentation. So we are now she has set the scene with the service delivery, reform about service delivery, bring an aspect of how can we improve or enhance the service, the referral system. So we're now going to move to the next pillar of the building blocks, which is another, again, self-delivery, but combined with the governance. So we're going to have Nancy taking us through, Nancy Agwanda from Cambry Wellcome Trust Research Program, taking us through a research I've done around understanding health system responsiveness to public feedback at sustainable level, subnational level in coastal Kenya. So Nancy is a health policy and system research at Cambry, as I told you, in Kilifi, in Kenya. She has worked with mid-level health manager in Kenya, examining coping mechanisms to a range of health system stressor and shocks, and exploring responsiveness to public feedback. Nancy research interests include health system accountability and responsiveness, primary care, and health system resilience. A warm welcome to Nancy. A warm welcome to Nancy. Karibu.
Thank you. I'm going to share with you findings from work that we conducted on health system responsiveness to public feedback in Kenya. And I want to start by acknowledging the contributions of my co-authors and also the funders that enabled this work, as well as the study participants whose data forms the basis of the analysis that is presented here. So, right? Okay. So how do I, this is the, okay. So by way of background, health system responsiveness is a broad, multifaceted and complex health system goal. And it's thought to be important in building people-centered and resilient health systems. But most of the studies that have examined health system resilience have focused on, evaluating service feedback by collecting feedback from patients. And these studies tend to report on satisfaction indices. And so the responsiveness is then predominantly depicted as an outcome of reactions to individual level feedback. And this is actually health service responsiveness rather than health system responsiveness. And so two recent reviews have suggested that one way to advance our understanding of health system responsiveness is to actually adopt a systems lens in exploring responsiveness and to focus on actors and processes. And so all right, sorry, this way. Oh, this way. Okay, sorry. And so in our work, we conceptualized broader health system responsiveness as how the health system responds more widely to the concerns, the views, and the needs of the public, and comprised of three interrelated processes, which is receiving, processing, and responding to public feedback. And we try to expand from whom responsiveness from whom feedback is received, which would include patients, marginalized groups, and the broader citizenry. We also drew on on Aragon's framework that describes organizational capacity as influenced by three interacting dimensions of system hardware and system software. And the software elements are, could be tangible or intangible software. So hardware refers to those visible elements of the organization. So the infrastructure, the funds, the human resource, while the tangible software would refer to things like management processes or the knowledge and skills within an organization. In this case, the health system. And then the intangible software would refer to things like the values, power dynamics within the organization, communication, and so on. In our study, so this is the research question that we sought to answer, how public feedback is received, processed, and responded to, and what influences responsiveness practices within at the subnational level. Yeah, there, got it. And so we adopted a multiple case study design in which, sorry, okay. It's quite sensitive. We adopted a multiple case study design in which we focused on the responsiveness practices of two governance structures within the health system. So these were sub-county health management teams. In other contexts, the equivalent is the district health management team, and they are linked health facility committees. And we adopted qualitative data collection methods comprising interviews, focus group discussions, observations, and document reviews. So, in our exploration of the process of receiving feedback, we found that there were multiple feedback mechanisms, a wide range of feedback mechanisms across the different levels of the health system. So right from the community level, moving up to the county level. And even though there was a wide range of feedback mechanism, our study respondents reported that there was very little public feedback that was picked up due to problems of functionality across the different types of mechanisms. And these mechanisms, particularly the participatory mechanism, tended to inadequately represent vulnerable groups. So a consequence of this limited functionality was that, God, this is really distressing. Yes, was that there was emergence of a lot of informal, there was a emergence of a lot of informal feedback which had mixed effects on responsiveness. So when we talk about informal feedback, what happened is members of the public tended to bypass some of these mechanisms that are the more formal mechanisms to engage with higher level system actors so that they could get responses for some of the concerns that they had. And the consequence of that was that sometimes that worked and there was responses generated to issues that they were raising. But sometimes the higher level actors would give directives that were disruptive to, for example, health facility processes, or sometimes the responses that were generated were short-term, and so, not sustainable and therefore not a system-wide response. And then because not every member of the public has access to high-level actors, then it creates an opportunity for selective responsiveness. So just to unpack the issues around limited functionality of the feedback mechanisms, the feedback mechanisms were constrained by what I talked about, the hardware type of factors. So these were the more visible things within the organization, such as the lack of adequate funding to establish one, and secondly, to sustain the feedback mechanisms. And then secondly, the fact that there was limited staff or limited staff who had responsibility for supporting the functioning of the feedback mechanism. And as a result, there were weaknesses in the tangible processes of how public feedback was managed. So you find, I showed that there were quite a number of feedback mechanisms, but these mechanisms really were not speaking to each other. So there was very little drawing of feedback from the different mechanisms to enable a system-wide response. And then often, much of the feedback that was collected was not documented, and across the cases that we were looking at, the sub-county teams and the health facility committees, there was little awareness of what is the process of managing public feedback, what are the guidelines available, and so on. Now, linked to that, so we've talked about the hardware barriers, which are the more visible things, but there were other things going on that seemed to influence whether funding was available or not. And one that I will pick is intangible software around power dynamics, where even though, for example, health managers might allocate funding in their plans to support, for example, training for health facility committee members so that they know what their roles are related to public feedback, would find that sometimes that funding was not available to them because a more powerful actor had moved around the resources that should support that kind of training. So, that not so much obvious on the surface, but working to influence funding available. Then there were other things that shaped health managers and health providers' mindset around public feedback. So we find that generally public feedback really was not a priority, given that there were already existing issues around staffing gaps and related health worker demotivation. So that's just to illustrate the interactions around these different dimensions within the health system or within the organization. So, just a little bit about the content that we learned. What was the content of the public feedback? So, unfortunately, it was predominantly negative experiences with the health system, and looking at to characterize from whom was this public feedback coming from, we found that it was reported mostly in a homogeneous manner. So it was hard to pick out what were the experiences of vulnerable groups. One thing that contributed to that was, if you look at that table, that's just the characterization of the membership within the health facility committees that we looked at. And there were few members of what are considered vulnerable groups. So you can see almost no representation of people living with disability, and very little representation of young people. I acknowledge that those numbers are very small, but the point I'm trying to make is that in these participatory mechanisms, often some of these groups that are considered vulnerable were missing. Then in thinking about now the process of generating responses to this feedback, we found that yes, some feedback was picked up, and yes, there were some responses that were generated, but again, these responses were sort of reactive, and so there were few system-wide responses, and when these responses were generated, often there was little communication back to the public. Sometimes it might not be very practical at the health system level to feed back to the public, but we should attempt to do some kind of feedback. So, I mean, just again, going back to the idea of hardware and system and software elements, the process of generating responses was also constrained by these kinds of interactions. Oh, God. All right, sorry. Oh, God. I just click once. Yeah, so I'm just going to pick out at least two of the elements and talk about, for example, like communication. So across the health system level, what we observed is that there was a tendency for information to go upwards, so like from the community level and up into the health system without coming back down, even, for example, to health system middle-level health managers. And then without coming back to middle-level health managers, I'll just talk about that slightly without going back. And so that constrained how much, for example, middle-level health managers could respond. They were limited in the kinds of responses they could generate to the public themselves. Then the public was predominantly dominated by actors within the health system, partly because members of the health system or health system actors perceived that the public had a little understanding of the health system and how the health system functions, and their views were seen mostly as subjective and so on. And so in conclusion, overall, this work demonstrates organizational capacity gaps that have resulted in weak to middling responsiveness across the cases under study. And the health system software and hardware gaps I've highlighted show some potential areas for action. But really, the key implication of, I guess, this work for me is that a weakly responsive health system suggests or gives us ideas around how much the public trusts the health system. And this is important because if there's low public trust, it can undermine public willingness to continue to give feedback, and it can also undermine the compliance of the public with health system directives. And I think we have a little bit of evidence of that from our experiences with COVID-19. And so these two issues are critical for health system resilience, because even though maybe there might not be consequences to incorporating public views into health system decision making, that latent distrust that is created by a feeling of our voices are not being included can manifest in public displays of resistance to public health interventions. Thank you, and I'm very sorry for the things with the slides.
Thank you very much, Nancy. The next presenter, running out of time, so the next presenter is Professor Laura Musango. Can you put the bio? So Professor Laura Musango is from WHO, the country representative of WHO in Madagascar. So he will taking us through a study they conducted in Mauritius. I'll about institutionalization of health financing progress progress matrix, progress matrix in policy making in Mauritius, and with immediate impact on policy making as well. So Professor Musango is a professor in public health. So he's currently I just want to summarize the bio quickly. So he's currently the WR in Mauritius. He has vast experience in teaching, leadership, but also at both international, regional, but also national. He used also to be my professor when I was still in the university. With due respect, Professor Musango, welcome.
Okay. Okay, thank you very much, Parfait. Good morning, everyone. Well, I'm going to make this presentation on behalf of other quotas who are not here. The one who was supposed to present is Ajoy. The first one, Ajoy Nandochan from Mauritius, but he was not able to come because of the crisis situation that you may be informed. So as I'm here and the quotas, I will present on behalf of all colleagues this institutionalization of health financing progress matrix in Mauritius. I did it when I was in Mauritius as WR country representative, but for the moment I already moved. I'm in Madagascar. But I contributed to this study. So I think I skipped one. Well, Mauritius, it's a small country in the Indian Ocean with a population of 1.2 million and with a situation of aging population which is declining. The fertility is under 1, it's declining. And they are well doing in UHC, as you will see when I will make that presentation. And also the UHC services coverage index was 68 in 2017 and moved to 66 in 2021. So the objective of this presentation, you know, the matrix elaborated by WHO. It's a tool with a several number of questions, and this tool is helping to elaborate a policy and strategy for the health financing strategy. So what we did, it is this assessment, and the results are important to engage policymakers, healthcare providers, community, and all people who are involved in the health financing. So in terms of methodology, as you can see, it's 4 phases. The preparation phases followed by conducting the assessment itself, and then an external review and a report. But the most important of them is this phase of conducting the assessment with different stages. And the first stage was the mapping of the situation of health financing in Mauritius. The mapping of everything related to landscape, comprising description of key health coverage, scheme which are existing, etc. And the second phase is related to assess 7 priority of health financing, 7 priority. And I'll show you the 7 priority. And within each 7 priority, there is a number of questions. 33 questions represent the area of health financing. And within each question, there is also other attribute, 19 attribute. You see, it's really a checklist of different things to know what is going on in the system, in the health system. When this survey was going on, we established a steering committee for following the process, followed by the online training with the colleagues from the headquarters. I don't know if Math is online and Joy, but there are also quarters. And Math is the one who supported for the training from Geneva to the team of Mauritius. And then the working session from the people of the Ministry of Health, WHO, and other health stakeholders in the country. And exit interview also were done for Health Economics, Statistics Institute, and Finance, all people who are really involved in the health system financing. Of course, a WHO internal and external assessment was done that show, as the assessment was like a own assessment, internal assessment by Mauritian themselves. Now the external evaluation was done by WHO, Geneva, AFRO, and headquarters. And then the phase 4 was finalizing and publishing the report by WHO and the Ministry of Health. So now, key result. For the phase 1, if you remember, which was the preparatory assessment, we went through this 12 attributes. It was focused on the scheme, target population, covered population, untreatment population, benefit, condition of access, revenue. As you can see, the 12, because of time, I'll not go through everything. And then the result, which is very interesting now for the objective. You will see now how, not before that, I'm to go back. You will see how Mauritius is doing well in terms of coverage rating by goals and objective. It is ranked in 4 steps: emerging, progressing, established, and advanced. So out of the 8 objectives of UHC, 3 of them are well done. Those are equity in finance, health security, and service use related to needs. And others are on the stage of established. Those are financial protection, quality, efficiency, equity in resource distribution, and transparency and accountability. So in terms of the health area, the 7 health financing area, you will see 4 of them are on the level of advanced. Those are revenue raising, benefit and condition access, public health management, and public health function and program. And other 3 need to be improved, which are health financing process and governance, pooling procurement, and purchasing and provider payment. The 4 need to be improved. So now this can show, this slide can show you question by question. Within each priority, this is the ranking for each question. So I'll not spend time to this, but if someone is interested, this was published in the BMC, and you can see the detail of this question by question, where Mauritius is doing well and where improvement is needed. So in terms of recommendation, as well, I will not take time for that because of the matter of time as well. But what I can say for the policy, process, and governance, Mauritius need to develop a national health care financing strategy and need also a medical insurance scheme which is aligning on the goal of UHC. They need also to harmonize and regulate user fees in the private sector, because the private sector is too expensive. And they need also to strengthen the existing structure nationalized with the Ministry of Health. So in terms of revenue raising, the big recommendation is to improve understanding of the driver of out-of-pocket. You will see the poor are the people who are still paying more and first on the out-of-pocket payment. And recommendation related to pooling revenue, the most important recommendation is to increase taxation and pulled in the consolidated fund of the government to be institutionalized. And other recommendation, as you can see on purchasing, really it's a common recommendation. And in terms of benefit and entitlement, they need to define again the benefit which are aligned with the availability revenue and health services. In terms of public financing management, they need to sustain the implementation of recommendation from the audit, because the Minister of Finance is doing regular audit and the National Audit Officer as well, but they are not implemented. So that needs also to be improved. And the last recommendation related to public health function is related to the procurement, especially in the time of emergency. You know, when it's coming to emergency, is the time that financial people are taking that opportunity to say that it's emergency, so we have to purchase this and that. That also needs to be improved. So to conclude, four important elements for conclusion. The first one is related to this assessment, and the one is efficiency, which need to be improved and developed, a policy which need also to be implemented. Second, in terms of equity, as I said, elaborating a new health financing strategy which is focused to the poor, not to the rich population. The third one is the transparency and accountability. This needs an implementation of recommendation from the audit report and the National Audit Officer and internal control. And in terms of financial protection, they need also a better understanding of the driver of the out-of-pocket payment and catastrophic health expenditure. Two more recommendation, but in the conclusion, is noting that this matrix influenced, and this is very good, influenced the Minister of Health to negotiate with the Minister of Finance for more resources. And you can see how it increased the annual budgetary allocation to the Minister of Health, increased by 10% in the fiscal year, this fiscal year 2024-2025. This really is the important, I can say the result, the positive result of this matrix. Usually it was 6.8, but it moved to 10, which is very good, and we hope that they continue to increase the budget. The last, before last, is introduction of program based on budgeting and aligning the recommendation of the matrix to the health sector strategic plan. And the last one is the financing of health services in public health financing, which is pro-poor and need to monitor and ensure that they are kept the low and the low possible and be focused on the poor and not consider really the people who are in the quintile 4 with some money compared to the quintile one. Thank you very much. And this is the end of the presentation.
Thank you very much, Professor Musango, for the good presentation. The next presenter is Mr. Jean-Bernard Bangou from the Swiss Tropical Public Health Institute. So he will taking us through his presentation around health system strengthening to improve governance in health system in Chad. So Dr. Jean-Bernard Bangou is a public health physician working in system strengthening health promotion at the STPH, Swiss STPH. He is currently the country representative in Chad and also the coordinator of the program d'appui au district sanitaire au Chad, which is funded by Swiss Cooperation. He holds a master's degree in public health from Marseille University in France and certificate in public management from Ohio State University in the United States. Jean-Bernard is also a Mandela Washington Fellow. His work interests are focused on health system strengthening and administration, and also passionate about impact he can have by working closely with community. A warm welcome to Mr. Jean-Bernard Bangou.
Thank you very much. Okay. D'accord. En anglais. Okay. Okay, good morning, everyone. I'm pleased to present you our work on the evaluation of the second phase of the program that I'm conducting in Chad. So the presentation will follow this agenda. I will go very quickly with the demographic and health system context in Chad because of the matter of time. So the country is ranked 189th out of 193 nations on the HDI, and 36% of the population is living under poverty. And there's a rapid growth of the population, about 3% per year. There's a weak health system with a low quality care, insufficient staff, irregular supply medicines. And there's also a limited geographical access to health services. There's a low rate of assisted deliveries and complete prenatal consultations. And particularly, there's a high mortality, maternal mortality, about 860 deaths per 100,000 births, which is very critical. And there's also, for the health access to nomadic population, it poses a particular challenge in Chad. The program is a 12-year program with 3 phases. Now we are conducting the third phase, and each phase is 4 years each, and it is implemented by a consortium composed of Swiss Tropical and Public Health Institute and Centre de Support en Santé Internationale, which is a Chadian NGO. And it is fully funded by the Swiss Agency for Development and Cooperation. And the activities are implemented in 2 provinces, the province of Bata and the province of Moyen Chari. And there is a competent transfer through the contribution to digital health transformation, One Health campaigns, operational research, the contracts of objective and means that we have with the different health structures. And there's also structural support with the construction of facilities and improvement of transparency, accountability through the participation of beneficiaries in health committees. The main objective of this program is to contribute to better governance and of the health system in order to improve maternal and child health, universal health coverage, and the prevention of epidemics. The first outcome, expected outcome of this program is that the health system resources are better managed at the central, regional, and local levels. And the second expected outcome is to improve availability and quality of health services in the program intervention zones. And the last expected outcome of this project was to improve equity of access to healthcare services, in particular for women, children, and marginalized populations. For the study, the objective of this study was to evaluate the impact of the project, and with the comparison of the results between two different surveys. Before the implementation of the phase 2, we got a baseline study, and after the implementation, we had an end of phase study in May 2022. And these data were collected at 3 levels. We had first the district level and the health facility level, and the data collected in the community. With the design of this study was a mixed method approach. And with the COVID-19 pandemic, there was a need to include questions on the impact of the pandemic on health access and health services in the survey conducted in 2022. Okay, for the indicators of the project, we followed the 5 dimensions of the 5 principles of the SDC for better governance. We have first accountability, efficiency, transparency, participation, and equity. So the indicators were organized according to these principles. And at the health district level, we got 2 indicators related to the management aspect of health facilities, which are transmission and availability of analysis of monthly activity report and cost recovery. Regarding the quality of care, we got 4 indicators: the use of curative consultations, vaccination coverage among people age under 11 months, and antenatal consultation and delivery, and also family planning and contraception. At the health facility level, the indicators were the existence of COSAN and COGES. COGES is the health management committees, and COSAN is the community health committees. So we work to strengthen these committees in the aim to have impact on the project. So the other indicators related to the aspect of health facility management were routine external supervision, the monthly activity report transmission and availability of reports or minutes in the health facility, and also the cost recovery. Regarding the quality of care at the health facility level, we got 3 indicators, which are the use of therapeutic diagnosis guide and standard operating procedures, the availability of contraceptive methods, and the availability of vaccines. At the community level, we also got some indicators. Regarding accountability, it was the information on the health facility activities, knowledge of annual activity plan, the use of health services, the involvement of the health committees, and the possibility of making suggestions. Regarding equity, we got 4 indicators. it was the prioritize of different population groups, the access and estimated time needed for a visit to the health center, the intra-household decision-maker power, the knowledge of gender-based violence, contraceptive methods, and situation of stigmatization. Regarding efficiency, the indicators were the quality of diagnosis and treatment, the infrastructure maintenance, availability of equipment, and working tools and services satisfaction. Regarding transparency, the indicator was the knowledge and information on services offered at the health center. And regarding participation, the indicator was the involvement of the population in management and opportunity to contribute and influence the community health planning. What are the results that we get from this evaluation? At the health center management and regarding health center management and accountability, we got an improvement of the external supervision conducting. In 2022, there were average 11 visits per year versus 6 visits in 2029. Regarding the reporting, at all health centers, except one, submitted the inventory and financial report on time for Q1 2022. Almost 100% of health centers submitted the last 3 monthly activity report on time in 2022. We also noticed an improvement of the cost recovery. For example, for Bata province in 2029, we got almost 17% of the health centers who got a normal recovery cost. And in 2022, the rate was 25%, which is an improvement. And in Moenchari province also, we got an improvement after the evaluation. We noticed the need to reframe on drug prescription and profit margin. Regarding quality of care, the medical guidelines were available in 50 to 75% of health centers, but still lacking for some conditions like tuberculosis and cardiovascular disease. For contraceptive methods, the availability improved. In 2022, we got about 92% of health centers that where we have these methods, and condoms were more accessible than injectable contraceptives. For the API vaccine, we also noticed an improvement regarding the availability of this vaccine in the health centers, except for pentavalent shortage in the province of Bata. The indicators of curative care improved. We got an improvement of diagnosis and management of malaria and diarrhea cases. Regarding transparency, we also noticed that the different health committees were more active and with a good representation of women in these committees, and also in improvement of social inclusion, particularly regarding nomadic population in these committees. For the equity, access, and use of healthcare services, we noticed that there's an increase among women, but among children, we got a small reducing of these consultations. Regarding the barriers to access, we noticed that there is a lack of universal third-party payer system with a low community awareness. For vaccination, we also noticed some progress. Regarding maternal health, we noticed also an improvement of prenatal consultation and assisted deliveries. For family planning, it remained a a concern despite the program support. At the community level, we noticed that the community improvement varies from community to another one, and some community felt engaged, while other community felt that they are uninformed and not involved in the different activities. For the health center accessibility and quality, functional health center exists for both sedentary and nomadic communities. The service quality improved. Also the accessibility and availability also improved. Regarding healthcare costs and perceived quality, most services are paid, with some exception varying by center. The population demands improved in service quality, staffing available, facilities, and medical supplies. Regarding gender and decision-making, women lack control on their financial resources and health decisions. Some sign of progress toward greater gender equity. Gender-based violence and male involvement in family planning remains a taboo topic, and many women acknowledge gender violence, but its prevalence is unclear. Regarding birth and maternal health, it's still common, and especially among nomadic women. Some women attend antenatal consultation visits, but they give birth at home due to cultural preferences and for female birth attendants, but lack of midwives. Okay. Regarding the impact of COVID-19 pandemic at the health facility level, we noticed that the health workers concerned, regarding the health worker concerned, 88% worried about contracting the COVID-19, and only 10% of facilities reported a COVID-19 case. Regarding training and preparedness, 47 health centers out of 49 received training. Most of them received only one training on infection prevention and control, and only 2 completed all the 6 modules. Regarding service disruption, 22% reduced operating hours, 20% adjusted service schedules, 25% of the health facilities felt staffing was insufficient, and 63% reported limited access to health care. The postnatal care and child vaccination were most impacted during this pandemic. At the community level, communities understood symptom and severity, but felt unaffected, seeing it as a foreign issue rather than concerned community and not rural areas. And disruption in healthcare services due to the pandemic restriction were especially noted by women. As a conclusion, we noticed an overall improvement in all the indicators under the PRDS phase 2, despite the COVID-19 and the post-2021 political crisis with the death of the president in this year. And we also register a significant progress in the management of health facilities and districts, as well as community integration via the health committees. The perception problem is that the improvement do not translate into increased public confidence in health system. And we also register that there is a stagnation of curative consultation, in particular for women and children under 11 months. The COVID-19 pandemic impacted especially on healthcare accesses for women and was perceived more severe by community than the healthcare staff. We also, there was also a poor monitoring of antenatal care visits, childbirth, and family planning in the community. the underrepresentation of the women in health committees, limiting the impact of pregnancy monitoring and the family planning. I will end with the recommendations of this evaluation for the next phase, which is phase 3. It is to continue the effort of maintaining and strengthening the gains made by the provinces, to strengthen the community awareness and communication, to strengthen community participation in the activities, to take a real account people's suggestion for improving health services, to improve equity for nomadic population, to strengthen better integrate women at all levels, and also to evaluate measures to further improve not only the availability but also the quality of services for the population. I think I'm at the end of the presentation, and I thank you for your attention.
Thank you very much, Dr. Chambenak Bangu, for the brilliant presentation. So the next presenter is Madam Wafa Abwelke Mataria from the Institute of Global Health and Human Ecology, American University in Cairo. So can you put the bio? Yeah. So Madam Wafa will taking us through a presentation on global health and in the grip of neoliberalism and comparative policy analysis using the stage heuristic model. So Madam Wafa, Dr. Wafa Abdulkair Mataria is a global health researcher and policy expert specializing in health governance, equity, and geopolitical determinant of health. She's a visiting research fellow at the American University in Cairo and hold a PhD in global health with a concentration in health policy and management alongside a master's in public administration focused on NGO management. Our work examines how global power structure, international aid, a commercial determinant shape health policy and access to care. A warm welcome to Madam Dr. Wafa. Is to change the slide is with the pointer, but you have to change the slide.
Okay, good morning, everyone. So this is a research that I did last year. It was a research with the Department of Global Affairs and Public Policy Department in the American University in Cairo. It was funded by the Ford Foundation. My research was concentrating about the effect of neoliberalism on health and health outcomes in countries. It's a little bit general. It's not specifically to Africa. So after COVID-19, as we all recall, we have been evaluating what had happened in COVID-19, and we have been criticizing what happened and the performance that has been done there. And one of the critiques that was really outstanding is that critique of the health system and the inadequate performance of the health systems during the COVID-19. When we look at the literature, we can see that the critique highlights certain points, such as the lack of preparedness and the overwhelmed infrastructure of the health systems, as well as the inequities in accessibility to health services and health products, such as the vaccines. These inadequate performances of the health system, they have underlying reasons. And when I looked in the literature, I found that most of them, they are a result of a long trend of concentrating on efficiency in health systems, on concentrating on underinvestment in public health sector, and on pushing for privatizations of health services. All these underlying causes if we look at them, we can connect them to something, to the neoliberalism and its proliferation as a dominant reform paradigm in the last decades around the world. So what is neoliberalism? Neoliberalism is an economic and political doctrine that advocates for certain things. Main things that neoliberalism advocates for is the limited government intervention in the economy. It also advocates for free market capitalism, for deregulation, and reducing social safety nets. Although neoliberalism is an economic doctrine, it profoundly affects public policies when it is taken as a backbone for structuring these policies. So it can affect all aspects of our lives. It can affect education, health, even the social structure of the society. So if we look at neoliberalism and the healthcare system, and we look at what it can do. So neoliberalism, it calls for privatization. So within the health system, it will result in reduced government role. So there will be an increase in the private sector as healthcare provider. And it also calls for market-driven policies, which means that in the health sector, we will be dealing with patients as consumers, not as patients. They will be responsible for their own health to get the medication. So if they don't have the money, it's their responsibility. It's not other person's responsibility. It also will deal with health as a commodity. It's not a right. It becomes a commodity. So whoever wants to get the commodity needs to deal with it. It also calls for austerity measures, which means that the government will decrease its investment and expenditures, and this will come to the public health sector and thus will infect the public health sector. So these will have effects within the health sector. The main effects will be that we will increase the reliance on the private healthcare and private health insurance instead of the public health service and free health services. There will also be increase in healthcare costs and financial barriers for patients. So the cost will increase, financial barriers will increase, and equity will decrease. There will also be a decrease in the equality and quantity of the public health services. And this is due to the lower government investment in the public health sector. So, what were the objectives of my study? The main objective was to know how neoliberalism became embedded in the health policies and through the setting the agenda, the policy formulation, and the government structure, the governance structures in the healthcare system. Second, I wanted to compare how the outcomes of embedding neoliberal philosophy in the health policies between countries that are neoliberal, non-neoliberal, and hybrid countries. Finally, I want to assess if there is a long-term effect of neoliberal doctrine in the outcomes, especially in the COVID-19, and if it's really true, can we really relate what happened in COVID-19 to the neoliberalism? So the methodology, I needed case studies. I needed case studies from countries who adopted neoliberalism, who were interventionists or who were hybrid. So to not be biased, I used systematic review. I went to Scopus and I searched for articles that have cases using keywords like neoliberalism and health reform. I ended up with studies covering around 11 countries. Then I took these countries, these case studies, and wanted to analyze them using the stages heuristic model. Stages heuristic model is basically the policy cycle framework. It has 5 steps: problem identification, agenda setting, policy information, policy implementation, and policy evaluation. And like this, I was able to explain how neoliberalism was through the health policy on all these stages. So I ended up having each and every country analyzed in 5 steps. But like this, I didn't have a comparison. So I used the comparative analysis to do a cross-country analysis and to compare between countries through their policies, if they have adopted neoliberalism or not, and what has been the effect on the health outcomes, health equities in their countries. So my results for the systematic review, as I said, I ended up with 27 studies included. They covered 11 countries: Senegal, Chile, New Zealand, Colombia, Turkey, Ecuador, Taiwan, China, Venezuela, Guinea, and USA. These were the case studies that I used for my next analysis. Then I did the policy cycle framework, and I took, as I said, each country and analyzed the 5 steps. I started with how they identified their problems. What was the problem that they faced that they led them to need a new public policy or a reform in health sector. The main problems identified was rising health care cost. It was in Chile. Some countries have inefficiencies and a fragmented health system. Others lack health service coverage. Others had economic crisis and limited resources for healthcare. And some has, or most of them has, inequity in accessibility to health services. So after identifying the problem, I went to agenda setting. I wanted to know how the agenda was set. Was there external factors that affect the agenda setting that included neoliberalism? So I found it was very interesting because most of them had economic crisis, high inflation, unstable level of public debt, currency devaluation, stagnation, and so on. A good number of them faced external pressure from IMF, World Bank at the time to implement certain agendas. Some of them shifted just from inside the government. They shifted their into a neoliberal political shift. Others, they have private sector lobbying, pharmaceuticals and so on, such as the USA. And some of them have social discontent that drive the agenda into a certain direction. As policy formulation, there were 3 main types of policy formulation among countries. The first type was a market-driven model, which went into privatization and insurance-based coverage. The second model went into hybrid model, which balanced the public and private services. And the third model, which was more socialized and state-controlled model. And I ended up this part of the analysis with the implementation. The implementation depended also on the policy that was formulated. So the first group, as we said, they privatized their services, and most of them ended with tiered health systems. So rich people will have better services, better access, and so on. The hybrid model ended with more balanced approach between economic gains and health service coverage. And the last one is the interventionalists, these that they didn't adopt neoliberalism, they ended up with public service expansion. Okay, so as we said, when I compared the countries, I took all the analysis that I did in the first step, then I put it in a big table like this to compare them. And I figured out that we had 3 categories of countries. The first category was the countries that adopted neoliberal approach. And the results in this country was that their majorly increase health inequities due to market-driven reforms, and access became increasingly dependent on financial capacity. Also, there were persistent systematic problems such as high out-of-pocket payments and dehumanization of healthcare in Colombia. The second group was the interventionists. These are the more of the socialists. They focused on expanding the access and state funding healthcare. They realized some successes, such as Venezuela and China. Initially, they improved the healthcare access, but most of these countries faced challenges, and most of them, they were financial challenges because they offered services for free or the reduced prices, but they couldn't cover the causes. So, and some of them faced some collapsed economic instability and so on, so they didn't continue. And the last category of countries was the hybrid, and it was mainly Taiwan. Taiwan faced the pressure, external pressure, in order to adopt neoliberal economic approach. They agreed, they took the neoliberal approach and they applied it to the economy. However, they preserved the public health sector outside of the neoliberal philosophy, and they promoted the universal health coverage. So they ended up having double gain, economic gain and good service coverage. So for the long term, as for the COVID-19, I looked in the literature and interestingly, I found it, there is a paper declaring that COVID-19 is a neoliberal disease. Well, actually, it's a little bit too much. I think, but actually what we noticed in the studies that neoliberal countries such as the US, the response wasn't really good. They had so many inequalities in the response. China and socialist economy, they try to prioritize the social aspect over the economic aspect. And as for Taiwan, their response was described as or recognized as proactive and effective. So what did we conclude? So we concluded that neoliberalism is really very, very important in health policies. It profoundly affects health policies, and actually it deepens existing disparities in the health system. In order to mitigate the neoliberalism effect on the health system, we really need to look at health as a common good. It's not any commodity. We can't treat it like this. It's a right. Health is a right. Also, we need a robust governmental intervention and regulation of the healthcare in order to ensure equitable access and to address negative externalities. And finally, we can't pin everything that happens on COVID-19 on neoliberalism because there are so many other factors that affected the country's response to COVID-19, and such as leadership, prior experience, economic resources, and so on. So even if neoliberalism is really affecting health policies, it's not the only reason for what happened in COVID-19. And thank you.
Thank you very much. So we're running out of our time. I will just request the presenter to go on the stage, and we'll allow just 2 questions for the audience for the sake of time. Or you can sit from where you are. People can ask questions for the sake of time. Let's allow 2 questions. Please let us know who will direct your question, and then.
Yes, thank you. I have a question for Chad. So thank you for a very good presentation. You said that despite the improvements, that you reported in your study, that the public perception about this health service delivery did not change. And I'm wondering why. Did you find out why? Did you measure utilization? Because it is possible that if people are not even coming to use the services, they might not, recognize the changes or improvement that you have brought about. So I want you to, respond to that. Why did the public perception not change? But the expected thing is that when you improve services, people notice and they help you to broadcast the information and they become your marketers, and that improves utilization even more. So can you respond to that? And for the study on neoliberalization, thank you so much for that. So my question is about your comparative study. So you compared with the interventional approach. Can you say a bit more about what that constitutes? Because you really explained what neoliberalism means. Sorry. Did you find out the details of those countries that were interventional in their approach to healthcare or health system reform? Can you explain more what the interventional approach is? Thank you.
Thank you. First, I would like to thank all the presenters for their valuable insight and study. My first question is to Professor Laurent. I'm so happy to see that there is a country who have already developed health progress matrix from as a tools WHO for assessing the health financing. And also, I appreciate the methodology used. There is a steering committee, technical groups. There is a wide discussion with experts from the country, and also the implementation, the publication of this study, and also the application on the policy use on the Ministry of Health budget negotiation. My question is about the Lakers scale. How to deal with the Lakers scale, widely used in the stage 2 for the health progress matrix, and sometimes we have some subjective answers. How to complete this subjectivity and objectivity. My second question to Dr. Wafa. Thank you also for your study. I have a very quick question and a suggestion. The first question is, what is the criterion to choose this country to make your comparative analysis about the impact of liberalism? My suggestion is to make this comparative analysis between subgroups of country, to make inside the same country with are similar in terms of economic liberalism or more government intervention, and to compare with the other groups of country. It will provide more robust results. Thank you.
How the to respond. We start by Dr. Bernard and then Dr. Wafa.
Okay, thank you very much. I think it's a very interesting question, and we need to maybe to conduct another study to go deeper and to know more about this issue. But we think that one of the main result that we got from this study is that some communities still feel that they are not involved in the process, and maybe this is the point. Even if you are doing great things and the community is not involved in it, maybe the few people who will come at the health centers will notice, but to have a great impact, you need to involve, the community. So this is what I can give like an answer, but to do it, to have more information, we need to go deeper with a study. Thank you.
Okay, thank you for the question. Actually, the comparative analysis was not interventionist, so it wholly depended on the policy cycle framework. So I took each and every country and analyzed it by steps. Then I compared between countries according to these steps. So I took it stepwise to see the differences in each and every step, how the agenda was set, policy adopted, implemented, and so on. So it wasn't interventionist. Yeah. As for the other question, that it wasn't about criteria in choosing the cases, because I didn't want to choose certain cases over others to end up with certain types of countries. So I left it up to the systematic review. So I did the systematic review. I ended up with all cases, which was really good because it gave me all types of countries. I had the 3 categories, and actually I didn't need to group them. The analysis itself grouped the countries, and I ended up with the groups from the analysis. Still, within the groups, there are so many differences. The common factor between groups is that whether they adopted neoliberalism, they didn't, or they adopted the hybrid approach.
Thank you
Thank
very
you.
much. Thank you very much for the question, interesting question, subjectivity versus objectivity. Of course, as you have seen the methodology, there is too many steps. The step of question, there is also quantitative data. There is also a discussion within the team to see how the answers are, to evaluate that subjectivity that can come in, and then discuss with the external teams also who is asking the question. And in the analysis, you are doing also the triangulation of those question and answer to try to be as much as possible objective. Of course, a bias can be there with a small subjectivity, but the methodology is trying to be as much as possible objective. Thank you very much.
Thank you very much. So we've come to the end of our session. So I'd like to thank again all the presenters and also the participants. It was my pleasure to be the moderator. My name is Parfait again Wali Rae, part of the local organizing committee of this conference. So thank you very much. Again, let's thank the panelists and thank again ourselves as panel. A warm applause for all of us. Thanks so much. Group photo. Okay, let's have the group photo. So we'll have the presenter and then let's have a group photo. So the conversation can continue with the presenters. Yeah. Beyond this session. Thank you.
Good morning again. I think we delayed a little bit, but we can start immediately with our session. My name is Jean Audier, who is going to facilitate this session. And I'm very glad that we are having an important session, which is related to the evaluation of economic evaluation of key health interventions in low, middle income countries, where there is a lot of things that we can cover in this session. As I said that we delayed a little bit, we can start with the first presenter, who is going to present on a country-led approach to leveraging digital technology for tracking resources flow to improve health sector resource planning and allocation, a Rwanda success story. So I can invite Mr. Eric Musengimana, who is the health sector strategic health financing within the Ministry of Health, to take us through for his presentation. Welcome, Mr. Eric.
Yeah, good morning. So we're going to have a presentation for a country-led approach to leverage digital technology for tracking resources which are needed to improve health sector resource planning and allocation. And this is a success story for Rwanda. So this is course, this is outline. We're gonna see the context and the rationale for HRTT, the HRTT background and development process, lesson learned and recommendation. So when you see this abbreviation, it is health resource tracking tool. It is called the HRTT, and it is a tool developed within the Ministry of Health. It is designed to carry out a report called the National Health Accounts in other countries. For us here in Rwanda, we call it HRTT report. So there are various reasons for tracking health resources depending on different contexts. For Rwanda specifically, the Ministry of Health wanted to track resources in a way that it can suit or informs their planning, budgeting processes on an annual basis. This was the main goal for developing this tool. And the focus was mainly about to understand the flow of resources from external funders, mainly development partners, since the public resources is already tracked throughout the AfHEA system, which is called the Integrated Financial Management System. It was evident that digitalizing the process of data entry and analysis of this data was important. And however, digitalization of this process was facing different challenges along the way. Initially, the health resource tracking tool was developed by international vendor, making system customization and additional features was also difficult because there was no access to source code. After completing the system with international vendor and he has left, so internally it was not easy to get this access to source code. The HRTT system was phased out, the first one was phased in 2016, and the process became manual again, using Excel for data collection and analysis. So the Ministry of Health also started to initiate the HRTT development by 2021 by using local vendor, which is called the Global Software Limited. So it started the second phase, HRTT development process. The first phase was just to initial development phase of local vendor. The initial development phase of locally owned the HRTT system officially started by 2021. And we managed to develop different modules. We developed the user management module, we developed the organization management module, we developed the data management module, and we developed the project module. Whereas in the second phase also, we managed to have different modules. And this second phase started by February 2024 with the focus to finalize the following modules to complete the HRTT system. There was data migration for 7 years for those existing Excel sheet data. They have been migrated into the system. So we also managed to develop a reporting module, and also we have external system integration. We have to integrate this underdeveloped the system with other existing systems which you have seen like AfHEA, and also we have made VAT deployment and documentation. This is in line to easy data triangulation. An analysis feature similar to Excel pivot table also has been integrated with HRTT to allow to do cross-tabulation of data, to make different data analysis, and also to complete HRTT report. So as of now, the system has already completed, development has been completed, and here it is a dashboard of the system, what it can generate as the reports, considering different financing indicators. It can allow us to generate total of expenditure, and this is the trend from 2020 up to 2022. This is the trend for total of expenditure. This is the trend for government expenditure on health as share of total government expenditure. This is the trend also for total of expenditure as share of GDP. Because we have health expenditure, you can compare it with the total GDP for the country. And also can have these different indicators for financing indicators like domestic as share of total of expenditure. Can have the share for external funding as percentage of total of expenditure. You can have also a portion of out-of-pocket as total of expenditure. And all of these, those are the graphs that can be generated with the tool. It can give you a trend for total of expenditure. It can give you a trend of total of expenditure as share of GDP. Yeah, you can see the blue and the red, all those are the trends across different years. As we have said that there has been data migration because we used to have those data into Excel sheets. And now they have been integrated into the system. And the system now can allow us to get those graphs and to have the data trending and to make different analysis throughout cross-tabulation. Next also, this is also system features for analysis. As we have said that the tool can do like a pivot table or can do different analysis. And this is the interface. You may see different projects within a different organization. You can see different activities under a given project. And the system can generate different different reports according to financing indicators. These are, for instance, this is the analysis, where you can see different sources of financing, and you can see where the money goes as the domain of intervention. You may see financing source like whether the money is coming from public resources, whether it comes from private resources, whether it comes from domestic resources, whether it comes from external resources or social contribution. Also, that is a domestic one. You can see also different domains under intervention where the money goes, and also can have a trend for different years and make different comparison as you want. As we have said, this HRTT is designed to allow us to be quick in data production and the data reporting, and also to have a national reporting for the status of sheriff expenditures. So we try to see how to integrate the data from different sources. We call data, we extract the data from AfHEA. This is for public health institution data. We come from our health centers, the district hospital, provincial hospital, and the university teaching hospital, all they are reporting into the AfHEA. And also for private pharmacies, we can have data, and this tool can be allowed to upload data from private pharmacies, and they are recorded into Rwanda Revenue Authority. That's why there is upload for Rwanda Revenue Authority as CFE format. And also we have data from private health expenditure, from private facilities. We have another tool called the HMIS. It is recording clinical data. Also, it is recording financial data. It records the financial data, both expenditure and the revenues entered into private facilities, and this tool can also accommodate all those data. Yeah, as we have said, the system functionality and the capacity building for users, the HRTT system is currently functional, and we have managed to do capacity building for the users, especially development partners, be it local NGOs, international NGOs, and the insurance companies, because they are to report into the HRTT. The functionality of system also is very crucial for doing analysis into the revenues coming from different sources. And those are the infographics, like a kind of report being generated into HRTT for our case for national health accounts. So there was different challenges during the scope of work. The scope of work might be changing due to leadership. Also, there is an issue for flexibility, which is necessary for this kind of projects, because you see the project has taken a long time. The project was initially initiated in 2020, and it took 3 years to be completed. So there was a need for cross collaboration for funders and key stakeholders to be successful in this development. And additional features also have been integrated, like pivot table analysis features, which was not planned in before. So for advantage, this is government ownership. The genesis of the project was due to the lack of access to source code owned by international vendor. And now the government decided to have a local vendor to own the system and to make different maintenance when the needs comes. Yeah, thank you very much. This is what you have for your presentation.
Thank you, Mr. Eric, to take through on a localized tool, which is helping us, which is now working as a national health account. I think maybe during the discussion, he might give another clarity to make sure that we get more insights. So allow me to invite Dr. Francis Adane from Ghana. He's going to present the paper on the cost of implementing anemia reduction intervention among women fish processors in Ghana. Can you please project his bio so that so he's a dedicated professional with a PhD in public health, and he comes from MPhil and psychology. So he's of course he got from University of Ghana, and of course his academic journey has marked his strong focus on the health system and public health, with much interest in the centered in the health economic evaluation. So I can invite Dr. Francis to take through to his presentation. Thank you.
Okay. Thank you. Good morning, everyone.
We can, Dr. Hamidu, if is allowed, or the team collaborated, you can be prepared to be in the next. Thank you. Sorry to stop.
Thank you. Like the chairman said, I'm presenting on the cost of implementing anemia reduction interventions among human fish processors in Ghana. These are I'm presenting on behalf of my co-authors. Okay. This is the outline of the presentation. By way of introduction, this project was implemented in Ghana in 2 regions. That was sponsored by Melinda Gates project known as Invisible Fishes Project. Invisible Fishes Project. So evidence suggests that anemia is very common, or the risks of having anemia is very common among human fish processors who live in less endowed communities. And so we decided to implement this intervention, or it was a pilot test in 2 regions of Ghana, as I've said, to reduce anemia among women in fish processing. So as we all know, anemia is a major global health issue that disproportionately affects women and children, especially those living in low and middle income countries. For instance, in 2019, anemia was found to be associated with 58.6 million years live with disability worldwide. And despite the implementation of several interventions targeted at reducing anemia, it still contributes about 9% of the global total disability, which is a major problem, especially in our environment in sub-Saharan Africa. In Ghana, anemia is classified as a severe public health problem according to WHO classification, and this is as a result of poor dietary of iron intake, malaria, parasitic infection, and maternal health issues. In 2022, Ghana Demographic and Health Survey report indicated that 41% of women aged 15 to 49, as well as children, 49% of children aged 6 to 59 months were anemic, which called for an urgent intervention to be implemented to tackle the underlying causes of anemia. In view of this, sorry, it keeps going back. Okay. In view of this, as I initially indicated, the Invisible Fishes Project was implemented. What's happening? Yeah. Okay, so you control it from here. Okay. In view of this, as I initially stated, the Invisible Fishes, sponsored by Melinda and Gates, was implemented in 2 regions in Ghana. And the intervention had 3 core components: anemia behavior change component that was mainly to provide information to participants concerning the causes of anemia and risk mitigation strategies through audio, mobile phone audio messages. The messages centered around consumption of micronutrient-rich anemia source foods, malaria and soil-transmitted helminth infection control, and water and sanitation hygiene best practice, among others. This component was part of component 2 and 3. And the second component has to do with improving market competitiveness and income of women, which was mainly to address challenges of inadequate storage facility, loan, and physical distance to market by giving interest-free loan to women, entrepreneurship training, and enhanced access to market information. Third has to do with the introduction and promotion of a new developed fish smoking oven known as ahoto, to reduce workload, increase earnings, and reduce harmful occupational exposures. And this was to replace the old choco, which exposed women to high risks of pollution and all that. Yeah, yes. So why is this study important? Despite the fact that the intervention led to numerous changes in the expected direction, for instance, at the end of end line, anemia declined by 4.9% across all the participants. But we know that determining the efficacy of intervention is not only considered, is not the only factor that is considered, but also requires the resource requirement that needs to be expended to implement the intervention. That is, both cost and benefits of the intervention need to appropriately be considered in order to inform evidence-based decision-making. Despite the fact that a growing number of interventions have explored the implementation costs of nutrition-related intervention to reduce anemia, most continue to do so by estimating only the financial cost to the neglect of the economic cost, which really underestimate the true cost of the intervention. So this study sought to just estimate both the economic and financial cost in order to present a true picture of the cost of implementing this intervention in these two regions in order to aid scale-up decisions. Okay. I don't know. Anytime I use it, it keeps. I think he was pointing there. Okay. 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 So by way of objective, the first objective was to estimate the financial cost of implementing the anemia reduction interventions. And the second objective was to estimate the economic cost of delivering the anemia reduction strategies among human fish processors. By way of methods, the study was conducted in the Central and Volta region. These regions were selected because of high prevalence rate of anemia. In Volta region, anemia was found to be 40%, and in Central, anemia was found to be 42%. Secondly, fish processing serves as a major livelihood for the people in these two regions, as indicated here. Then descriptive cross-sectional design was used to estimate the cost using ingredient-based approach. The time horizon for the project was 23 months, and cost was estimated from the societal perspective, meaning that all stakeholders that took part in the implementation cost were estimated from them. Data was collected from all 120 human and community volunteers. Cost data was obtained from the financial and logistic records of the project. Travel time of human community volunteers and caregivers' time were equally obtained through interview to estimate their indirect cost. In estimating the direct cost of the Invisible Fishes project, we try to identify both recurrent and capital items to estimate cost. Recurrent items refers to the cost of items with useful life of less than a year, and capital items are those with useful life of more than 1 year. 3 years useful life was assumed for computers, printers, and all phones, and 10 years for the Ahoto oven. Indirect costs were analyzed using human capital approach, where financial value was used to place on the time that participant used on the project but were not remunerated. All costs were reported in 2080 US dollars using the Bank of Ghana average annual exchange rate of $1 to 4.59 cedis. Results. The financial cost of the Invisible Fishes project. The average cost of implementing the financial cost of the Invisible was least in the anemia behavior change at $4,308.48, followed by the strengthened market engagement with anemia behavior change, estimated at $8,180.3. The most expensive component was the fish smoking technology, that was estimated at $11,185.79. Personnel cost was the major cost driver in all the intervention components, with 59, 58, and 57% for anemia behavior change, market engagement, and fish technology. And this is the total cost of the financial cost of the Invisible Fishes project. By way of, in the economic cost, the indirect cost of implementing the intervention was highest in the strengthened market engagement with anemia behavior change, estimated at $30,941.86, followed by the fish smoking technology component, $27,000, 719.62. Average cost of implementing the anemia behavior change was 4,651.93, and of course that was the least, followed by the SME, which was 8,962, and again the most expensive was the FST, 11,000, that the fish smoking technology, that was 11,896.62. Again, personnel costs followed the same trend as we saw in the financial costs. Sensitivity analysis. We conducted sensitivity analysis to test the robustness of the cost estimate. And so we conducted both one-way and multi-way sensitivity analysis. So we varied the discount rate. The base golden standard of discount rate is 3% according to the literature, but this usually vary based on the context. So we vary to 5% and 2% to see the effect on the cost estimate, and also made some assumptions as say if community volunteers who were not remunerated, if the indirect cost of time happens to be the amount they were to charge or remunerated for their services, how will there be the impact on the cost estimate? However, we did not see any significant change in varying those parameters and assumptions from the base case. The same trend followed in the multi-way sensitivity analysis, with the exception of scenario 3, where we saw an increase in all the intervention component when we assumed that at least community volunteers were paid an allowance equal to their indirect costs, and then we varied the discount rate to 5. That saw an increase in almost all the intervention components. But apart from that, all the other components remained the same or were the same as the base case estimates. Conclusion. From societal perspective, implementing the multi-sectorial anemia behavior strategy of the Invisible Fishes Project was the cheapest option to reduce anemia. And I must also say that that was intervention that saw the highest decrease in anemia cases from 6.7% as compared to the other component. Generally, the Invisible Fishes Project was found to be expensive when implemented among small population compared to other forms of anemia reduction intervention that were implemented in the sub-region. So if policy makers who want to implement any of the components, we advise that they implement the multi-sectorial anemia behavior change, because that saw the highest decrease in anemia cases as well as the cheapest option as well. Thank you.
Can you give him again another applause, because I know how straightforward with this technique and analysis, and I really thank the team, because your dedication is a result of this one, which is a very insightful. I hope you're writing down the questions, and so that we should have a strong discussion in a few minutes to come. So let me invite Dr. Hamidou Niangari from Bamako. He's going to take us through the cost analysis of implementing a digital tool for community healthcare in Isegu, Mali. Dr. Hamidou is a PhD holder in economics from France, and he also a dedicated medical doctor who have get a lot of experience in both community-led clinical sector, of course, medical research, at malaria research at Training Center, University of Science, Technique and Technology of Bamako. He health program implementing monitoring officer at the regional health directorate. Let me invite Dr. Hamidou to take us through to his presentation. Welcome.
how it works. Okay. Thank you, dear Chairman. Good morning, everyone. So my English is not good, but I will try to be clear. Okay. So our work focus on the evaluation of the cost of a program that implemented at the community level, which is the community alpha digitalization. Okay, it's coming. Okay, so in Mali, the community health work has activities, preventive care, including communication, mass drug administration, and vaccination. They do also curative care regarding malaria, acute infection, respiratory malnutrition, and TB. We do also epidemiological surveillances, and these health workers, community health workers, are supervised by the delegate supervisor and the head of community health facilities. Oh. Doesn't work. Sorry. Okay, so I understand. Okay, for the purpose of the program development, from March to September 2021, the national strategies have been developed, and in December 2021, the community roadmap have been elaborated. And in Mali, before, we have many tools that we're implementing in the community level. And in the context of health system, community health tools called Disc Mali have been chosen to implement the community digitalization health program. So from 2022 to 2023, the program have been implemented in one region, the region of Segu. So these tools are directly linked to the national health information platform. Okay, so we adopted the societal perspective to take account the resources mobilized by the government and the community, and the temporal origin of the study was 2 years, from 2022 to 2023. So the objective of the study was to evaluate the cost of the Disc Mali tools, including the development and the implementation phases in the Segu region, and specifically to determine the direct and the indirect cost per level of health system and per phase of development, and to determine the unit direct cost and unit indirect costs per level of healthcare system and per development phase. And finally, to assess the level of contribution of each partners. Okay, in terms of methodology, the targeted population was the community health workers, but we also interviewed supervisor, local focal point, informatician, and the program managers. So we adopted top level and bottom level method, meaning that we collected information at the central health system levels, at the regional levels, at district level, and at also community levels. So at the central levels, we identified 7 structures in which we conducted interviews with tens personnel directly involved in the implementation or the development of the programs. In the regional levels, just one region, and at this level, we conducted interviews with 2 personals. We selected 5 districts of 10, from 10, and in the district levels, interviews have been conducted with 10 personals. At health area levels, we selected randomly 66 health area, and there we conducted an interview with 10 health head of health facility and 15 dedicated supervisors of community health workers. So at the community health worker levels, we selected randomly 183 community health workers, and to determine the time, to compare the time between community workers who were using the tools and those who were not using the tool, we measured the time of healthcare of 48 children. So our protocol was approved by the ethical committee, and we divide the cost parameters in the 4 groups: the human resources, the consumable, and the fixed and the overhead resources. For each items, we calculate the percentage of resources used by disc-mali activities, and then we calculate the direct cost of disc-mali if the item is directly linked to the disc-mali, we take all the costs, and if not, we take 50%. Okay. In terms of finding, in terms of time, so here we have the time for community health worker who were not using the tools, the disc-mali, and here we have the time, the total time in minutes for health workers who were using the tools. So the difference between the 2 groups of health workers in terms of time was 12 minutes, meaning that the tools allowed community health workers to gain 8.2% of time. So the total cost of the program was $509,809, and the unit cost was $836. The direct cost was higher than the indirect cost, representing 87%. So if we look the cost per development phases, so the cost of the implemented phases was higher than the cost of development or the startup phases. And if we look the cost by the types of resources, the cost of human resources was higher than the fixed cost or the consumable cost. And if we look the source of the resources, so the partners was the main contributors to the programs, and the contribution of the government was 28% of the cost, and the community contribute around 2%. And if we look by level of the system, the costs incurred by at community health levels was higher than the cost of the other health system levels. Then in conclusion, this pilot study showed that the cost of digitalization of the provision of care by community health workers was substantial, and mainly due to the human resources and the IT resources. And regarding the positive impact of the tool in terms of time gain, and also we did another study on the acceptability and the feasibility, and this study found a positive result, and we think this tool can be used at nationwide. But the evaluation has been carried out in one region, and we need to deeply study these programs. So thank you for your attention.
Thank you, Dr. Hamidou. I think you have captured your questions. I think this is another interesting moment. Let me invite Mr. Jeffrey to give us through cost effectiveness and the budget impact of introducing a new tonic for the prevention of PPH in India, Nigeria, and Uganda. Welcome.
Yeah, you have a presentation. So good afternoon. So my name is Jeff Jacobs. I'm with an initiative called MSD for Mothers. We focus on addressing preventable maternal death. And my specific responsibility is identifying and advancing innovations that can support that mission. And so I'm going to speak to you about one of the elements and one of the investments we've made around some cost effectiveness modeling. I am not a health economist, but have been working with some health economists across India, Uganda, and in Nigeria, and some other implementing partners to develop this model. Let's see here. Next slide, please. So we'll go through typical outline, introduction, key objectives, methods, results, and conclusions. So back in 2018, WHO updated its recommendations related to the medicines used for the prevention of postpartum hemorrhage. Postpartum hemorrhage is defined as bleeding after birth, and it's the #1 direct cause of maternal death globally, and certainly in low middle income countries. As any good practice, when we think about new interventions, whether they be particularly new innovations, good practice should be countries, we need to evaluate their value, their cost benefit, and the budget impact that they have. And so that's what we've tried to do here. But thinking about postpartum hemorrhage, as mentioned, it's the leading cause of maternal death. The medicines, uterotonics, which contract the uterus, can be very effective and can reduce and prevent PPH by about 2/3 as long as they are effective. Optimizing prevention of PPH, of course, can support the mother herself, the family, her family, but also government sustainable development goals. Unfortunately, current uterotonics, those medicines that are used to prevent, are not optimal. They are life savings when they're truly effective, but there's some optimization issues that exist. And so when WHO introduced this new normative policies, both recommendations and into their essential medicines list, they included a new alternative called heat-stable carbetocin. And it's that medicine that we'll be evaluating compared to the standards of care in this analysis. So as you can see, heat-stable oops, go back. All right. So the heat-stable carbetocin is the intervention. Oxytocin, which is the global standard of care. Misoprostol, also used regularly in particular contexts. And then there's a lot of anecdotal evidence that providers are using the combination of oxytocin and misoprostol. We undertook this analysis to help inform country governments as they think about, including or not, this new intervention of heat-stable carbetocin, right? Just as a decision tool. Obviously looking at both clinical and cost benefits to try to understand the value for money, right? We considered the public healthcare system perspective, and we also considered some quality issues specific to oxytocin that really have been intractable for nearly the past 50 years or so, because it requires cold chain. So the model included a number of inputs, actually over 300 different inputs across 3 different buckets: general information, clinical information inputs, and economic inputs. And we had a hierarchy of inputs that we utilized. We first tried to identify local reference data. Many of us know, unfortunately, local data sometimes is challenging to capture. When that local data was not available, we looked at peer-reviewed international reference data, published data. And when neither of those were available, we used local key opinion leaders and clinicians to better understand some of those inputs. We used a typical decision tree, rather simplified decision tree model, starting over on the left-hand side, looking at birth, separating between vaginal delivery and cesarean section delivery. And then we compared heat-stable carbetocin as the new kid on the block compared to the standards of care, oxytocin or misoprostol, or the combination of the two. We looked at, did they require retreatment after that initial prophylactic dose? And then we looked at, did the women have PPH or no PPH? And if they had PPH, was it mild to moderate? Was it severe? And then hopefully she survived. Sometimes, unfortunately, she dies. So that's the model that we used. In terms of the results, we first looked at the incremental costs. Again, remember, because heat-stable carbetocin was the new medicine, we were always comparing heat-stable carbetocin versus the other alternatives, the standards of care. And just to make it simple, because India, Uganda, Nigeria are very different, of course, from a population perspective, et cetera, we equalized, the results you'll see are equalized on a 100,000 births cohort, just to make it simpler to read. So from an incremental cost perspective, what you see, the interventions are on the left. In the middle is, on the left is India, middle is Uganda, on the right is Nigeria. And what you see is that for every 100,000 births shifted to heat-stable carbetocin for prevention of PPH, there's substantive cost savings forecasted in all but one comparison. Of course, as mentioned, local healthcare systems, structures, and cost particularities differ, and they drive the differences between the country results. In terms of effectiveness, what you see here is that heat-stable carbetocin consistently shows an incremental benefit compared to all the comparators across all effectiveness metrics and countries modeled. The effectiveness metrics we used were all PPH events, a subset of that, specifically severe PPH events, and then death. And as you can see, all of the comparators had a higher number of PPH events, a higher number of severe PPH events, and a higher number of deaths as compared to heat-stable carbetocin. We did some, to try to understand the robustness of that base case, we did some sensitivity analyses, looking at the probability to save costs and avert mortalities compared to the comparators. And what you see, if you look at the first column, oxytocin, you see 95% and above where heat-stable carbetocin is dominant. Better health outcomes at a lower total cost to the healthcare system. If you move over all the way to the right, similar, that combination of oxytocin plus misoprostol, up 86% and higher percent chance that heat-stable carbetocin will be dominant. Save costs, better health outcomes. And for the middle column, for misoprostol, in India, Uganda, extremely high probability to be dominant. For Nigeria, specific to misoprostol, no dominance. The issue around no dominance here for Nigeria and misoprostol is really an issue of health equity. As I showed you earlier on the effectiveness slide, better health outcomes with heat-stable carbetocin versus misoprostol, but at a slightly higher cost. So really, what's the health equity in that? Do we want women to bleed, be at risk of death, or do we use something that you need to pay a little bit more to ensure better health equity? Yeah. And then finally, switching over to budget impact, what you see is as heat-stable carbetocin scales, so at the bottom left, we use just some penetration levels for heat-stable carbetocin, going from anywhere from 0% penetration all the way to up to 30% in year 5. What you see on the left is that as heat-stable carbetocin scales, you have budget savings increase, and on the right, the clinical impact deepens. More and more positive, favorable outcomes in terms of less and less PPH events. So to conclude, preventing PPH should be our first act, right? We want to prevent, and it's really that first line of defense to prevent women and to reduce healthcare system burden. It's our view that heat-stable carbetocin for the prevention of PPH optimizes health outcomes, promotes health equity and quality of care, supports a more efficient healthcare system, increases budget savings and population-based clinical impacts. And because of this cost effectiveness and budget impact modeling, we believe that it warrants inclusion into country programming. And we know that across Africa and other countries, it is slowly but surely gaining interest. Kenya is scaling, Sierra Leone is scaling, and a number of other countries are considering. But we wanted to provide this tool, again, to help inform those decisions. Of course, for any model, there are limitations. We did not think about indirect costs. This is just direct costs. The decision tree is quite simple. We didn't think about non-pharmaceutical medical interventions, so it underestimates the total cost. We didn't include tranexamic acid, which is a new medicine with some new evidence for the treatment of PPH that would have reduced probably some of the overall health outcomes. And we didn't include any metrics around the poor quality of misoprostol that we see regularly in studies as well. But we think that the model is quite robust. Finally, just to acknowledge that the data for India has been published. The data for Uganda has been accepted and should be published at any moment. We're just waiting for it to be released by the journal. And the Nigeria data is currently been submitted for publication and is under peer review. And if you have any questions or potential interest in doing this kind of modeling for your own country, the model is quite adaptable. So as long as we have local data, we can generate a model for your own country. So if you're interested, my contact information is there. Thank you very much.
Thank you, Jeff. Another applause because this is a very interesting We have another presenter, but I don't know if she's allowed tonight. Okay. If not, I think we can proceed with our next agenda, which I think is going to be another interesting moment where we can share some insights. And if you need any clarification, we'd like to ask the audience to ask some questions, but be brief and specific to the point, and also you can say who the question is addressed to. Thank you. The floor is yours.
Thank you very much. My question is for the last speaker. My name is Jeffrey. What's the advantage in publishing country by country? Where is the comparative dimension in the publishing? I mean, is there any reason for publishing India, Nigeria separately and so on?
Just simply that individual governments, they ask for their own tailored modeling. While we believe that we can use information from one country and extrapolate it to another, many don't agree with that. And so the intention has been, where there has been an increasing interest in cost effectiveness analyses, to support generation of those models.
Thank you so much for the interesting presentations. My name is Bolanle. I work for Apps Global in Nigeria. I'm Nigerian and I understand the context you have presented. So my question is about your analysis. Definitely having a heat stable, alternative to oxytocin is a welcome development. We know that oxytocin, which is the most commonly available product for preventing PPH, is actually not effective many times. And unfortunately, at the lower level, this is not commonly known. And so we have midwives storing oxytocin in cabinets and in the communities, in homes, when they're not effective. But my question is about the comparison with the prostaglandin, misoprostol. So you showed that study that showed that there was no advantage, in some instances. And I want to say perhaps that has to do with the mode of administration. So you can, insert, misoprostol compared to the IV, route of administration for carbetocin and oxytocin. Did you look into that? The fact that it is easier even for, community health, community midwives who are like community health workers trained to have, some, skills in delivery and effective life-saving skills for maternal health. Did you look at that probability? And you were talking about, the advantage of having, a product like carbetocin that is more life-saving, but you have to look at economic, realities. So if it is more expensive, on the to even buy it on the shelf in the first instance, that could be an hindrance. And we know the other advantage of not having to procure cold chain should be a good, at least in cost effectiveness. But the prostaglandins like misoprostol have that advantage of ease of administration. And so I don't think we should discountenance that. I think it's a factor that should be looked at, in terms of equity as well. Because if community health workers can easily administer misoprostol, then that is why it's probably not showing that, significant advantage for carbetocin when you compare them. Thank you.
So excellent point. If you look at the WHO recommendations, they look at misoprostol largely for home-based births or community-based births. The analysis is really for heat-stable carbetocin is an injection, so it really needs to be with a trained healthcare worker in a facility. Right? The analysis was suggesting that it's slightly more expensive, but that the health outcomes, based on all the efficacy trials that have been done, heat-stable carbetocin has a better efficacy profile. More efficacious, more effective, more effective, but not necessarily, it could be more costly in the context of Nigeria. The inflation issue in Nigeria really changed the dynamics you saw for Uganda and Nigeria and India, despite a significant difference in price, even between misoprostol and heat stable carbetocin, it remained dominant. But that inflation issue in Nigeria was quite significant. So there's no discounting the life-saving properties of misoprostol. We were just doing a simple analysis based on data that's available.
Okay, thank you. My question goes to the last presenter. I would like to know the rationale behind your exclusion of the indirect cost. Was it not substantial enough? And excluding indirect costs, will you think that it will present a better picture for policy making? Thank you.
It's a great question. Clearly it's a limitation of the trial, of the study. What I guess the reason why we didn't include it is because it's just one component of the overall response to PPH management. And in fact, even for EMONC, BMONC, right, broader. So training, whether it be on PPH prevention, treatment, refractory, oxytocin, misoprostol, and everything else should be something that's integrated across the system. So it's not specific to heat stable carbetocin, if you see what I mean, right? So that was, but again, it's a limitation, understood. Yeah.
Thank you. Rahul Madumba, University of Southern California, and I have a question for the last presenter, not to pick on you too much, but take it as a compliment because I enjoyed the presentation, but I have some quibbles with the transparency and I'm a little bit lost on some of the inputs that went into it. On the front end, you mentioned adapting it to different contexts, which makes sense. And I know a lot of the driving factors of that would normally be costs that are adapted to the healthcare system. I'm curious because I didn't think I saw it on the slide, but if I'm curious as to if any of the efficacy measures or effectiveness measures were also adapted in terms of quantifying how efficacious the intervention was and in different contexts, or if any calibration was involved on that end. And then another one I was thinking was, I appreciate the fact that you did the probabilistic sensitivity analysis and reported the findings, but I think a more convincing thing to me as a third-party viewer here is if you use those Monte Carlo simulations to maybe map out, a distribution of different pricing scenarios to make it, in a Bayesian sense, more cost-effective and where that price range would fall. And if you reported the confidence interval for that, I think I'd be convinced as to what price reductions or scenarios would affect the model results. So I think just takeaways in terms of like transparency and like where models came from, what the numbers were, which ones were adapted to different contexts, I would benefit from some clarity there. And in terms of different scenarios, I think would be another good clarification point, if that makes some sense.
Yeah, I just wanted to concur with the other question about indirect costs, because for adoption of technology, many policymakers will ask this question: what are hidden costs? So omission will undermine actually the adoption of very critical intervention. So I would really having a picture of what are the indirect costs, it will be very critical, even though it is not related. But although it is not unrelated, but in the actual decision will be related.
So thanks for the questions. So the efficacy data that underlies this comes specifically from the efficacy data that WHO used for its recommendations. And that was based on a meta-analysis of all uterotonics of, I think it was 135,000 women across the world from 197 studies. So it's based on that efficacy, indirect and direct comparisons of efficacy studies that have been done across the world. So rather robust set of data around the efficacy side of things. The inputs, there's quite a few inputs in there around that you couldn't see just because of time. We looked at death rates at efficacy rates and death rates and anemia rates at lower level facilities, middle level facilities, higher tertiary level facilities, added anemia rates, added referral rates. I mean, there's a whole slew of 300 and something entrants. So we tried to be as robust as possible. Again, just for time, I wasn't able to present all of it, but it is in the paper that maybe give you a little bit more confidence. On the PSA stuff, again, I'm not a health economist, so it's really hard for me to answer the question. But if you have the questions, if you saw, hopefully you captured my email, if you send them to me, I'll make sure that it gets to the health economists that drove the model, and I can get the answers to you on how best to do that. But certainly want to be transparent, but hopefully the paper and the papers, the India one that's already published, and the Uganda one that's coming out very soon, hopefully that will add to that transparency that you're talking about. And in terms of the indirect costs, again, limitation, totally understand. Part of the rationale was heat-stable carbetocin is an analog of oxytocin. It is administered the same exact way that healthcare providers today use oxytocin. So we didn't see a big difference. Where the indirect costs would come would be training on the slight small differences that exist between the molecules. But it's not a huge difference in the innovation itself. Right? But again, totally understand that it's a limitation. And we're seeing that, right? We've had a number of questions. How much is it going to cost me to train providers on this as part of the decision making?
Yeah, I think let me get another opportunity. I think, yes. Oh, okay. Go ahead. I was going to ask another question.
I have a question for Ghana. I made me totally forget questions I plan to ask him. So the women that process fish in the Upper Volta and the Central regions, I understand they represent an economically disadvantaged group. Obviously, that's why we chose them. But is there any particular reason why it has to be the women that process fish and not farmers, for example, or women selling other things in the market? Did you purposely select them, as kind of convenience sampling, or was there a reason you were interested in those fish sellers? And I like your intervention because it went beyond the direct determinants of health to social determinants of health. Looked at anemia in the context of being an index or, of poverty or lower socioeconomic status. And that was why you included the new technology, to reduce the hardship they go through, and then the other economical, strengthening, interventions that you did. And that makes it really broad. Wanted to do something on a larger scale about improving people's economical status. I hope you get my question. Thank you.
Thank you for your question. First, I will start with the rationale behind choosing the women in that space, the fish processors. The rationale behind, in the beginning of my presentation, I think I made mention that literature has indicated that women who are engaged in fish processing activities from low-income communities are at higher risk of anemia compared to other who are engaged in other livelihood. And similar study have been conducted in Ghana that found 80% chances of women in fish processing activities of getting anemia compared to others and other literature. So that's the rationale behind choosing the women in this space. And the prevalence of anemia in those among the women too was found to be higher. And there was a base study that also pointed out that women in that occupation had a higher rate of anemia. So that was the rationale behind. Regarding the broad interventions, yes, this intervention, I said it was piloted, so the time span wasn't enough. That's why we didn't do impact analysis, because we could not do impact analysis looking at the time frame and even the number of women who were sampled. Basically, they wanted to know how the methods or how the process of implementing, either it will go through the same process, how it was hypothesized that we want to implement this. So they were looking at feasibility of the implementation. That was the main focus. And so they also needed to know the cost, even if they want to pilot. So this was not to test the effectiveness of the intervention, but yes, but just to see how feasible will it be to implement it, to inform the decision of a scale up. So we just look at the baseline and L-line changes, not specifically impact, because it will be difficult to associate this change to the impact of the intervention. Thank you.
All right. Hello, thank you. My question goes to the third presenter, the one on Mali. I don't know if I missed it, but you talked about indirect costs, but if you could throw more light on what exactly did you measure as or use as a measure of the indirect cost that you measured in your analysis. I also want the rationale behind the different sampling techniques that you used, because it looked like you had different sampling techniques for the various things that you measured. By the end of the day, you were compared them saying that the chips compared to the others had higher costs, higher direct cost. But if you are using different sampling techniques to select these things, I'm wondering how you could compare these outcomes. Thank you.
Okay, thank you for the two questions. The indirect cost include, for example, in the health system, we have personnel that are engaged by the government, not directly linked to the programs. So if we use this personnel, you need to calculate the indirect cost. It is the same for the building or for the other items. Yeah. And for the sampling process, so we did not compare this different level of, sorry, we compare the cost at different level, but we at each level, we include, for example, at central level, we include all personnel directly involved in the health system. But at the operational level, for example, at the health area, we have 10 health districts. So we selected 50% of this district, represent five health districts. And in the health area, we have 200 health area. Then we cannot conduct the survey in this all area. We selected 30% health area. Yeah.
I think this was a very excellent reaction, and I think we owe them applause because they did a good job. And we are still having more time to discuss outside of this room. But before we wrap up for this session, I think I have some quite few reflection for this excellent session. I think one is, of course, there is a need of national ownership and sustainable financing in a health resource tracking, where we saw that Rwanda journeys from externally developed digital tracking system to our homegrown health resources, which underscore a critical lesson in economic evaluation as, of course, when there is a national ownership is in a fundamental way to sustain and with long-term effects in health financing. So I think when a country depends on externally developed system, of course, we face challenges, as I mentioned, that are relating to limited adaptability, high maintenance costs, and also vendor lock-in. Another reflection is on cost effectiveness, which I think I can say that CAA is not alone is not enough, which means that the context matters in the decision making. And also, as you have seen, the India, Nigeria, Uganda study on heat stable carbotocin for PPH highlight an important real CAM, which must be contextualized within any health system constraint. Of course, he mentioned that there is some limitations, but of course, as you're familiar with economic evaluation, you can't exhaust everything. Of course, there is some assumption that you have to take, and which of course can vary from context to context. And so, of course, what matters sometimes we have to look at both cost effectiveness analysis and the cost efficiency analysis, which of course give you the right way to decide if you can go with carbotocin or the traditional way of dealing with the PPH. And of course, for decision makers who are around here, of course, they should go beyond, as I said, for those cost effectiveness metrics by incorporating budget impact analysis, which of course can give them the idea of not go directly or immediately for the implementation, but also this economic evaluation reflection. Of course, we have to factor the real world constraint, which of course I mentioned, but it will not stop us to use or to adapt with the new way of dealing, because what matters is the process and what's the cost relating to the process. Another reflection on, of course, my brother said very well, sometimes when it goes to scale up, sometimes you have to make sure that size effect comparison between the cost of intervention matters, and we have to accept that between these Ghanaian anemia intervention and the Mali, those are the things that we have to think and use economic tools to challenge our health economics understanding. But of course, the cost of small scale sometimes it might, of course, challenge us to think the scale up. But of course, I can encourage you that you can continue expanding a little bit and see how we can have a strong factor to scale up by looking at the size effect of intervention, but also looking at the cost per se for both. Because sometimes, as someone said on indirect cost, sometimes it might be another issue which might be stopping us to believe that a change must be done. So I think it was very wonderful. It was very wonderful for me as someone who do economic analysis, and I was privileged to read this modulation, and yeah, I think we can stop by here. Of course, we are not stopping the discussion around with these insightful topics which was presented here. Thank you very much. Have a good afternoon. Thank you.